Welcome back. This is Dr. Lewis, and the purpose of this video is to discuss normal adrenal function. So what you're looking at right here is simply a PowerPoint slide with a bunch of squares, a circle, and a kidney with some adrenal glands. So super simple. So we're going to fill in this slide with some stuff, okay? Because I'm a big proponent of the fact that you need to understand normal function so that you can understand abnormal function. So as we've already established in a thyroid video, apparently the anterior pituitary gland in this PowerPoint is just going to be upside down, much like it was in the thyroid gland. We're just going to move past that. So we're going to add some information here. So the anterior pituitary gland, much like it does with the thyroid, it's kind of got an overseer function, and it's going to secrete a hormone that's going to stimulate the adrenal cortex. Okay, this is called ACTH, or adrenal corticotropic hormone. Okay. And its job, it's going to have a negative feedback mechanism just like the thyroid. So that means that the anterior pituitary is monitoring the adrenal gland, the adrenal cortex, and if it sees a lot of excess adrenal or cortisol and aldosterone, it's going to back off. Okay, if it doesn't see a lot of cortisol treatment, it's going to increase its secretion of adrenocorticotropic hormone, or ACTH. So ACTH is going to stimulate production of the adrenal hormones, the adrenal cortex hormones. So let's talk a little bit about what that's going to look like. So the two hormones secreted by the adrenal cortex, the first one is cortisol, okay, and the other one is aldosterone. We're going to come back to this because I want to talk about the three S's. Okay, when you think about Cushing's disease, Cushing's disease has actually 4 S's. All right. Well, I'm going to talk about 3 S's no matter what. Cushing's. I lied. 3 S's. So the 3 S's I'm talking about are salt, actually sugar, salt, and sex hormones like androgens. And those are your 3 S's that are going to be involved with a lot of what we're talking about today. Okay, sugar, salt, sex hormones. And cortisol is the sugar portion of this thing. And what I want you to think about with your adrenal glands is stress response. Okay, so if you think about your stress response, if you have an acute stress emergency, let's say that your patient suddenly goes into VFib, VTAC, you have to start CPR. You're going to have an influx of hormones in the form of epinephrine and norepinephrine. That's your adrenal medulla. The adrenal cortex is about your long-term stress response, because if you think about it, if you need, a bear's chasing you through the woods, you need energy really quickly. That's your short-term stress response. Your long-term stress response, you still need energy, okay? And when the epinephrine and norepinephrine wear off, you still need to be able to maintain energy. So cortisol is part of that. It makes more glucose available to manage long-term stress. Remember, this is all about your long-term stress response. Think about it. When someone is in the hospital and they have pre-diabetes, their glucose goes up. When someone has an infection, whether they have diabetes or not, their glucose goes up. And the reason why that happens is because of cortisol. Cortisol is a hormone that's secreted when the body is under physiologic stress. Okay? And the idea is to make more energy and fuel available so that the body can continue to function in a stress environment. Now let's talk about aldosterone. Aldosterone is the salt end of things. So if we say aldosterone is salt, and what it does is it increases renal absorption of sodium. I know I'm going to have to make my box bigger. And it causes potassium excretion. All right, so let's fix the box first. Yay, okay. So aldosterone is going to increase renal absorption of sodium. And the reason behind that is when you're under long-term stress, you also need to maintain a blood pressure. So this helps with blood pressure maintenance. And remember, aldosterone is the last part of the renin-angiotensin-aldosterone system. So the whole purpose of aldosterone is for maintenance of blood pressure, and it is the salt portion of this. There's also some secretion of androgens that occur within the adrenal cortex. So just to kind of give you an idea of where we're going with this. So I'm going to pause the video because I'm going to pull up a Word document. So once again, with Cushing's and Addison's disease, this is an endocrine disorder. So with endocrine, you either have too much of something or not enough of something. And in the something we're talking about is aldosterone and cortisol. And so we're going to look at each of these disorders with a side-by-side comparison, much like thyroid, because this is really, in my opinion, this is how I envision these disorders as you look at them, because they're really a study in opposites. So the disorder that has too much of these hormones is Cushing's. So you have too much cortisol and aldosterone. And yes, I know my lines are going to get all funky here. So think about that through. So we have too much cortisol. So even though it's not an electrolyte, here we're just going to say electrolytes / labs. And one of the labs, cortisol is sugar. So I'm expecting with that excess cortisol, I'm going to have hyperglycemia. Let's follow the money trail then. The aldosterone, we said, promotes renal conservation of sodium and potassium excretion. So what that tells me is I'm probably going to have a hypernatremia, because that's what aldosterone does. So if I have too much aldosterone, I'm going to have excess salt. I'm also going to have a hypokalemia. Easier said than typed. Another thing that can occur with all this electrolyte stuff is a hypocalcemia, because you have increased renal excretion of calcium along with all this other stuff. So with Cushing's disease, you have hyperglycemia because of the excess cortisol, hypernatremia because of the excess aldosterone, hypokalemia because of the excess aldosterone, and you also have hypocalcemia because of an increased renal excretion of calcium. So these things are going to relate back to a fluid volume problem as well as electrolyte problem. So in this case, with hypernatremia, water follows salt. So you would expect the patient is going to be experiencing a problem of fluid volume excess. And you're going to probably see weight gain. Let's talk a little bit about those signs and symptoms. And these are the ones that we keep talking about when we talk about long-term corticosteroid use. Okay, so let's talk about the changes in fat distribution with the buffalo hump. So that's a development of fat pads on the back. So you develop a buffalo hump. Okay, moon face, again, accumulation of fat in the face. Truncal or central obesity. So that's accumulation of fat in the stomach area. Other things that can happen, okay, you're going to have changes to the skin. So you can develop striae, which is stretch marks, okay, and they can become colored or they can just be that kind of shiny white stretch marks. And then you can have easily bruising skin. Okay, and it's not because of a clotting factor issue, it's because the capillaries become fragile. So you have increased fragility of the capillaries, creating striae. Because you've also got those excess androgens, for women, you may develop increased facial hair. For men, they may develop gynecomastia, which is development of breast tissue. Okay, poor wound healing. Remember, we give corticosteroids, and corticosteroids have an immune effect. So you might see poor wound healing from someone because it's basically an excess of a glucocorticoid. because of decreased immune response. You also can have, I mean, the gynecomastia, sorry. Talking and typing and they're not going the same. So you can have gynecomastia. There's also a risk for fractures because the patient has osteoporosis. Because when you have an increased renal excretion of calcium, it's going to pull calcium from wherever it can, in which case it's going to be the bones. So you have osteoporosis. You can have hypertension. You're going to have an increased risk for infections. Okay. Thin, fragile skin. Okay. And also muscle wasting. So muscle wasting in the extremities. And so think about a grape. A grape is round. Okay, and then stick two toothpicks in the grape for legs and two toothpicks in the grape for arms. Okay, this is kind of what they say. So somebody with Cushing's disease is going to have a lot of body mass in the central area of the body, but on the external portions of the body, the extremities, you're going to see muscle wasting, and so you're going to have skinny arms and legs. Okay, so those are the signs of Cushing's disease. As far as treatments go, you're going to give medications that are going to suppress the production or the release of these glucocorticoid hormones. So one of the things is ketoconazole. Another one of these is called mitotane. And finally, they also can just take out the adrenals. They can take out one or two of the adrenals. So they can do adrenalectomy. And I have a spot here for emergent treatment. However, there's generally not an emergency related to Cushing's. We are going to talk about Addison's or adrenal crisis in the next video. But this is the brief overview of what happens when you have too much cortisol or aldosterone. I'm going to stop the video here, and I'm going to start the video up the next video up, and we'll go over the same thing with Addison's disease. Thanks for your time and attention.